The impetus for this study was that there is now CMS coverage for patients with heart failure to get coverage for cardiac rehabilitation. Previously, only patients that had had CAD with an event such as a myocardial infarction, a valve surgery, a heart transplantation were eligible for cardiac rehabilitation. This has been shown to be very beneficial in patients previously eligible with CAD and an event to reduce hospitalization, improve quality of life, improve mortality. The HF Action study was completed in 2009 and published and showed that cardiac rehabilitation and exercise training for patients with heart failure and reduced ejection fraction with stable heart failure had improved similar outcomes in that they had an improvement in mortality, improvement of heart failure rehospitalizations, improved quality of life. Secondary analyses showed significant improvements in depressive symptoms in many other areas. CMS expanded coverage to cardiac rehabilitation in February 2014, launched a new treatment for patients that we knew was beneficial but wasn't necessarily covered. So if you don't cover it, it's hard for our patients to actually get access to this care. So what we tried to do in this study was really get a feel for how many patients this new expansion of cardiac rehabilitation to chronic heart failure patients with reduced ejection fraction actually expanded that population to. We used the Get With the Guidelines Heart Failure Registry, which is an inpatient registry, which may have some limitations to an ambulatory chronic population, but it's what we had. And from 2008 to 2012, there were 55,000 patients enrolled. And we looked at patients that were previously eligible based on previous guidelines that I mentioned. So really you're talking about patients with coronary artery disease, valvular disease, heart surgery, PCI, and was our kind of previously eligible population. And then we looked at a newly eligible population, so folks with chronic heart failure with reduced ejection fraction, and then that were on goal-directed guideline medical therapy of ACE inhibitor and beta blockers at time of discharge. We did have to assume that patients were stable at this time of discharge. Typically, from the CMS coverage, you should be stable for 6 weeks. So that's one minor limitation, I think, but it still gives us a slice. What we ended up demonstrating is that in this group of 55,000 patients, approximately 7,000 patients were previously eligible. Now another 12 to 13,000 are eligible. So we expanded coverage from about 14% of a heart failure population to 42%, so tripling the overall coverage. I think another interesting finding of this study is that we saw that there's still 58% of patients that are ineligible for cardiac rehab coverage by CMS guidelines. Those patients are largely patients with heart failure with preserved ejection fraction. There's a small amount of patients, we did not specifically look at this, but if you look at the baseline characteristics of patients that would just not be on this because they weren't on guideline medical therapy, because you need to be on guideline medical therapy. However, if you were intolerant to those therapies and that was noted on the case report form, then that would not have been an exclusion. So initially, cardiac rehabilitation was built for patients with coronary artery disease and had recent myocardial infarction, taking them from bed rest and improving their symptoms and hoping the body would recover, to patients post-PCI, and that was studied and demonstrated that they had improved outcomes. But then there were small studies in patients with heart failure because patients were surviving their coronary disease, now having heart failure later on in life. Small studies originally started showing positive results. Patients were doing better. And then the landmark HF Action trial of 2,300 patients were randomized to exercise. So supervised 12 sessions of cardiac rehabilitation versus placebo, basically saying, hey, you should exercise and do activity. And it showed improvements in outcomes. So I think now we do have data from coronary disease, so previously eligible patients, and our newly eligible patients with chronic reduced ejection fraction as an HF Action. The supporting guideline evidence came out in 2013, and it says it's a Class 1 recommendation for exercise training, which means you should do this, and it's a Class 2A recommendation for cardiac rehabilitation, meaning you probably should do this. I think we have support from trials to do this. However, for this ineligible population, as evidenced by no CMS coverage, we don't have a large randomized control trial in patients with preserved ejection fraction. It wasn't that it wasn't offered, it's just that CMS, so which in basically the position that pays through Medicare, did not reimburse for that because they typically need to analyze the data, talk to experts, and kind of follow on. So the guidelines came out in 2013 supporting this, and then they have a statement and an expansion of coverage in 2014. It probably seems slow, particularly if you're a patient, but if you think of a big clinical trial finishes in 2009, disseminating the message, that's still less than we normally think of 10 years taking for a therapy to be proven to be novel and helpful to then kind of really get into common.